So in multiple sclerosis, we often wonder whether relapses have long-term consequences of patients or whether the term relapsing, remitting multiple sclerosis is truly true. And we know from research, from ample research that has been done, that the term remitting is probably not a completely correct terminology, because patients with attacks, following attacks, always have some things that is left behind. Sometimes it may be very little, and sometimes it's more. We even see this in patients with optic neuritis, where there is a decrement, for example, in color perception persisting even after they have recovered from the optic neuritis. Why do we treat relapses with multiple sclerosis? Very often we use corticosteroids or other interventions to treat relapses. The goal is to shorten the relapse and perhaps also make the depth of the relapse less significant. These are obviously approaches in order to mitigate the impact of a relapse. In reality, what we really want to do is not to have the relapse in the first place, and that's where an appropriate disease-modifying therapy for multiple sclerosis comes into play. Do relapses have impact on a person's functioning above and beyond what we see, for example, with impairment of motor function? Yes. At the time of a relapse, patients very often express increased fatigue. Sometimes there is also mood alterations present at the time of a relapse. And lastly, we are always concerned with a relapse that there is an enduring deficit that is unmitigated by the later recovery of the patient. A lot of interest is obviously given to a more formulaic approach to treatment decisions in multiple sclerosis. This is something that is important to payers. It is also something that is important to practitioners that are perhaps less familiar. One of the challenges we have in multiple sclerosis is the fact that disease is so variable. At the same time, both payers and many practitioners would like to have a more algorithmic approach to the treatment of multiple sclerosis. What this would mean is that one indicates where to start, how to progress with treatment in individuals. What this also means that options that both address patients with milder disease, patients with more beneficial properties on their MRI and in their presentation, or patients with more aggressive disease, with more significant findings on MRI or clinically, would have access for appropriate treatment from the get-go. Currently, we very often have the step edits from payers where older agents need to be approved and used first. Such an algorithmic approach, as for example presented by the Consortium of MS Center, would allow attribution of treatment to patients dependent on their disease activity grades, their severity grades, or the prognostic features that are presented. In the end, one of the challenges that we face in multiple sclerosis is the fact that patients very often come with different and differing disease phenotype even at the earliest features. So when we apply such algorithms, such as the one proposed by the consortium, we need to keep in mind that one needs to implement this with the best interest of the patient and the long-term goals of reaching no disease activity in this patient as soon as possible.